All right, well, looks like we have a pretty good number of folks on today, so thank you again for joining. My name is Sarah Cariano. I'm the Senior Health Policy Analyst at the Virginia Poverty Law Center, and I will be the presenter for today's webinar. We'll be talking a little bit about Medicaid and then how the federal public health emergency related to COVID-19 has impacted Medicaid, and then what will happen when that public health emergency does end. There we go. So for those who may not know, Virginia Poverty Law Center is an advocacy organization based in Richmond, Virginia, where we advocate, educate, and litigate on behalf of low-income Virginians in an attempt or in efforts to break the systematic barriers that are keeping low-income Virginians in poverty. One program that we administer that I am very involved in is our Enroll Virginia program. And Enroll Virginia is the only statewide Navigator program since 2013. A Navigator program is a program that's funded through the Affordable Care Act to assist individuals with ACA, marketplace enrollment, as well as Medicaid enrollment. We do a lot of community education and outreach in addition to that, and complex case help. So we have 23 folks across the state, and we can provide services directly in multiple languages. And we also use language lines and other methods to assist individuals who need assistance in languages beyond these. And this is where you can have our website there, as well as our toll-free hotline. And so you can go there and find more information about the Enroll Virginia program, as well as locate assisters in your community. The hotline will ask you for the zip code, and then it'll just direct you to the local Navigator in your area. So it's a great way, just a great resource to keep in mind as we're going through this. If you or individuals that you work with or in your community need help with Medicaid, we'd love to be that source of help for you. It's a little more just about what our navigators do. Again, we do one-on-one assistance. We do a lot of education, enrollment. We do appeals and special enrollment periods and all of those great things. So please reach out if you need help, or if you'd like to do some kind of training or education, or you're throwing some kind of health fair, please let us know. Okay, so now I'm going to kind of get into the meat of the presentation. I will stop at certain points throughout to check for questions. Deepak Mandala and Mara Geyer, who are also at BPLC, are monitoring the chat for me while I'm presenting. So they'll let me know if there's questions in there. Please do feel free to put questions in there, the question and answer, and then we'll certainly leave time at the end to respond to questions as well. Okay, so the Families First Coronavirus Response Act was passed and signed into law on March 18th, way back in 2020. And one of the provisions in that was that the federal government said that we will give states an extra 6.2% FMAP. So the federal Medicaid assistance percentage is the percentage that the federal government is paying for the state's Medicaid program. It changes by the state. Virginia's is a 50 state, 50 federal. And so to get this extra 6.2, so for Virginia to get 56.2% federal funding for the Medicaid program during the public health emergency, we had to meet certain criteria that were outlined in the law. You couldn't make any more new restrictive eligibility rules, couldn't increase premiums, you had to cover the COVID testing, treatment, and vaccination. And the really big one that we're going to focus on here today is that states were not allowed to terminate or reduce coverage for any individual who is enrolled in Medicaid as of March 18th, 2020, or who became enrolled during the remainder of the public health emergency. And so what that means is we haven't been able to terminate or remove anyone from Medicaid coverage for a really long time at this point. And so what that has done is that we have over 2 million people on our Medicaid and FAMAS programs in Virginia right now, which is the largest enrollment that we've had in those programs. Part of that is due to, just about a little over a year before the public health emergency went into place, January 1st, 2019 is when Virginia implemented Medicaid expansion. So we got this whole new group of individuals in the Medicaid, and now there's over 600,000 individuals enrolled in that category of Medicaid alone. And that's the group for our 19 to 64-year-olds who aren't parents, who don't have a disability, but have income under 138% of the federal poverty line. For that whole period, we've also been getting this additional federal match. So while we've been covering many, many more Virginians, the state is actually net over $1 billion, even taking into account this increased enrollment. So we're covering a lot more people. We've also taken in a lot more federal dollars than we would without this provision. There are a few exceptions. So when individuals actually can and have been removed from Medicaid during this time, if someone moves out of state, right? So Medicaid is a state-by-state program. And so Virginia is not going to cover someone who moves to New Hampshire. New Hampshire is going to cover that individual. If someone asks to terminate their coverage, right? So I don't want to be on Medicaid anymore. I've got no job. I have job-based coverage. I would rather just use that. Certainly, the state will not force you to keep the coverage. And if someone passes away, obviously they can be removed from the rolls as well. The other exceptions are for our CHIP population. So CHIP is a Children's Health Insurance Program, and it's kind of built upon Medicaid, where individuals with slightly higher income can still get public coverage. In Virginia, we call our CHIP program FAMOUS. So the famous children's category is the FAMOUS, and the famous moms category is for pregnant women. These individuals can be and are being disenrolled from coverage when they meet the end of the eligibility period for them. So for the famous children, that's when they turn 19. And for the pregnant individuals enrolled through famous moms, that was 60 days postpartum. And then July 1, Virginia expanded our postpartum coverage for famous moms and Medicaid for pregnant women to a full 12 months. So now those individuals are going to be staying for a full 12 months until that they are no longer kind of categorically eligible, what we call, for that type of coverage. There's also the smaller group of individuals who are sometimes called CHIPRA 214 non-citizens. So this is a group who we are allowed to cover at a state option through the CHIP, Children's Health Insurance Program Reauthorization Act, or CHIPRA, and it's from Section 214 of it, hence the name, where we can cover legally residing children and pregnant people who do not meet the quote-unquote qualified immigrant status, which is what most non-citizens have to meet to be enrolled in Medicaid. And so we have a broader category of eligibility, or broader eligibility criteria for non-citizens who are children and who are pregnant. These individuals are also able to be and are being disenrolled again when they turn 19 if in the children's coverage, or when they hit the end of the postpartum coverage period if they are a pregnant individual. And then we also in Virginia have a famous prenatal category, which covers individuals regardless of their immigration status. And again, these individuals will lose coverage at the end of their postpartum period, which is 60 days. Even with the 12-month extension, this small group of individuals will still only get 60 days coverage. So we don't know when the public health emergency is going to end, but when it does, and why we think it's a good idea to start talking and planning now, is because DMAS estimates that between 14 and 20% of those who are enrolled are going to lose coverage, which is up to 400,000 individuals. And as the public health emergency goes on and more people come enrolled, that percentage, that number of people who are represented within that 20% grows. So we're going to have a lot of coverage disruption and coverage loss when the public health emergency ends, and we need to be prepared to help those people figure out where they should go and how to get coverage, and hopefully do it as quickly as possible so we don't have a lot of gaps in coverage. There's an additional estimate that after kind of the quote unquote unwinding period, which is 12 months after the public health emergency ends, an additional 4% will kind of, who have lost it, will actually regain coverage and come back into Medicaid. And so there's going to be this returning of churn, which is when eligible people are falling in and out of coverage, usually for like administrative reasons, not necessarily eligibility reasons. So despite the fact that we do not know when the public health emergency will end, CMS has issued a few rounds of guidance telling the states what they will have to do and how they can approach kind of what we call the unwinding or returning to the normal operations, right? In Medicaid, normally there is the annual renewal or the annual redetermination period. Just like I need to sign up for my health insurance at my job every year, the state and Medicaid recipients need to check the eligibility every year so that only eligible individuals are enrolled in the program. And individuals often will lose coverage at that point in time. So when the public health emergency ends and we have to start doing all these renewals again, CMS has provided some outlines that states there are some guidelines that states are going to have to follow to make sure that they're reserving the rights of Medicaid enrollees, to make sure that we're not going to have a lot of improper disenrollment, so people who are eligible losing coverage to the extent possible. And so I'm just going to go over kind of the high level of what some of those requirements are, and then what the timeline for that process is going to be. So the MOE, which is kind of that maintenance of effort continuous requirement, ends at the end of the month that the PHE ends, right? So if the public health emergency ended this month, that means no terminations, that continuous coverage requirement would go through until the last day of this month. And so no terminations would be able to occur until September 1. States will have a full 12 months to initiate all of those renewals. So they are going to hopefully be spread out. And then they're given an additional 2 months, so a total of 14 months to actually complete all the renewals, because the renewal process actually takes a few months for each individual. States will be allowed to initiate that renewal process actually prior to the public health emergency ending, up to 2 months before. But really, the terminations cannot happen until after. And then that extra federal bump, that extra 6.2% that the states are getting for their Medicaid programs, will continue until the end of the quarter that the public health emergency ends. So we'll have a couple months extra of maintaining that extra income that we're getting from the federal government while we're working through this process, but only a couple of months, right? That's maybe 2 months of the full 12-month period. CMS has said that they will give states a 60 days heads up prior to the end of the public health emergency. So we'll have at least some amount of time to really kind of kick it into high gear. I know the state has been doing a lot of work preparing to the best of their ability behind the scenes. But once we get that, notice, it'll be like, all right, it's really go time, I think, for them as well as for organizations like mine and community partners. And then just for a little context, the public health emergency is only extended for 90 days at a time, a maximum of 90 days. And so every 3 months, we're waiting for the next one to get kicked out, which is part of why we just honestly don't know when it'll end, because CMS can continue to extend it within those 90-day increments. So what all that means, in a still pretty confusing chart, admittedly, is that right now, the current public health emergency in that first column does expire October 13th. August 14th was 60 days prior to that, and CMS did not announce that it would be ending. And so we know kind of all but for the formal announcement of the extension, the public health emergency will be extended again. So 90 days from October 13th brings us to that middle column, to January 11th. Now, 60 days before that date is November 12th. So we would hear by November 12th if it were to be extended, if it was going to be extended again or not. If we got that notice that says, okay, we're within 60 days and this is going to be the last extension, it's not going to be extended again, then we go down that column. So Virginia has said that previously, and it may change, right? Everything I'm saying may change if there's new guidance or other things come out. But as of the last I heard, Virginia would initiate the renewals in the month that the PHE ends. So they would start triggering that process in January. And then it would take a couple months for the renewal process to go through, which I'm going to talk about later. So likely the first terminations would be in March of 2023. And then that higher match, right, that end of that quarter, the first fiscal quarter of the year is January, February, March. So that extra 6.2 bump would continue until the end of March. Now, if November 12th comes and we hear, and comes and goes, and we hear no notice that it's not going to, we are not within 60 days of the end of the public health emergency, then we know it'll be extended likely for another 90 days, which would bring us out to April 11th. And then you can kind of see the dates accordingly below that as to when, we'd be looking for notice again, and when the initial renewals would be started, and all of those dates. So I'm just gonna pause there and just ask you back, Mara, are there any questions in the chat about any of that? Or does anyone have a question they want to throw in the chat right now, kind of before I continue?
Sorry, I don't see any questions at this moment.
All right, so then that's kind of the guidance around the timing. Now here's a little more guidance around the process. So once it does end, when we're unwinding or returning to normal, no termination can occur unless a full renewal has been completed. That means that the state can't be like collecting a list of people who are no longer eligible, and then as soon as the PHE ends, kick them off coverage. They have to go through the entire renewal process as it is outlined in like federal and state regulations and code. The only exception is if someone had gone through a renewal or been determined initially within the last 12 months, they can do they could potentially do a partial review and just say, okay, you're no longer eligible, because they're saying the data that you have is recent enough. You've done a full eligibility determination recently enough where if you get information that this person is now over income, we'll kind of let you do a partial review that may result in a termination. But for folks who haven't been through that kind of full determination within the last 12 months, workers will be allowed to hold changes in circumstances until kind of the pending scheduled renewal date. They won't need to be processing people twice within the same 12-month period when the workload is just going to be incredibly high. CMS has recommended that they cannot require that states distribute the renewals throughout the course of the year, and that they initiate no more than 1/9 of the total caseload in each month. I know Virginia has been working to try to stay on top of what it would look like to be able to spread it out through the full 12-month period. And I think that is still the goal. And then CMS is, they've put in some additional reporting requirements and monitoring. And so they said, we need to make sure that you are following these guidelines properly. And if you are not, we may, we have the right to put a corrective action plan to get you back into compliance with regulations. Okay. So I'm going to go through each of these steps in a little more detail, but this is a very high level overview of what quote unquote the full renewal process is. An ex parte renewal is an automatic renewal where they try to automatically renew someone using electronic data sources. If that is not successful, then a renewal package, a paper renewal package is sent out, and the individual needs to complete it and return it. If what they return shows that they are no longer eligible or they do not respond, so they get the state gets no response back, then a termination notice will be produced and mailed. And it has to be, delivered prior to the termination. And appeal rights do apply to a termination notice. So if someone is losing coverage and they think it's improper, they can appeal. And then even after someone has been terminated, if they were terminated because they didn't respond, they didn't send that renewal package in, there is a 90-day reconsideration period where they can just return that renewal package and have that information entered versus doing a full new application. And then that coverage would go back into effect back to the termination date. If they miss that period as well, and they're outside the appeal window, which is generally 30 days, then the individual would have to reapply. Luckily, Medicaid applications are accepted year-round. So, if folks do lose coverage, we certainly would encourage them to go ahead and they're outside of all these kind of other windows, get that new application in as quickly as possible. So that the first step of the process is this ex parte renewal process. Again, it is no touch for worker, no touch for the enrollee. It is automatic. It cannot, and it is not used currently for any category of Medicaid where there is a resource or asset requirement. And so it's just what we call our MAGI. They are modified adjusted gross income, the income only populations, which is Medicaid expansion, our children, our pregnant individuals. It can result in a renewal into your same category. It could also result in a renewal into a new category. So a child who has turned 19, 20, 21 at this point through the public health emergency could still be renewed into Medicaid expansion, but their coverage category would change because they're no longer categorically eligible to be in a children's coverage group. Same for a pregnant individual who is outside their postpartum window. They'd have to be looked at to see if they were eligible in different categories, and ex parte can be used for that. Our state has a pretty good, success rate with our ex parte renewals. It's 75 to 80%, which is really, really good news. I will say on calls with other states and advocates from other states, these This rate is much higher than a lot of other places, and I hope that will help us through at the end of the public health emergency when we're having to go through just so many renewals within that 12-month period. When someone is successful, great, they just get a notice that says no action is needed, you're enrolled, here's your new renewal date. If that notice of action is returned because it was undeliverable, right, state mail can't be forwarded, and so if it gets come back, that actually will not result in a termination. So a lot of times return mail does result in a termination. This specific instance, that will not be the case, which is also really good news. And then if it's not successful, that renewal package is sent. And the person has to respond, right? So the renewal package is sent when the ex parte fails. It's also sent to enrollees who are in a category with assets and resources, because they need to just kind of manually enter any changes in that information. The renewal package generally it's pre-populated with your information. So the member needs to go through and make sure everything's accurate and then correct anything that's not, as well as complete any blank sections. They can do this on the paper form and return it to the local DSS, who's going to be the entity that kind of is doing the case management for them. They can also just call Cover Virginia, and the Cover Virginia rep should be able to access the renewal in their computer system, and they can complete it over the phone. Or if the individual has an online Common Help account, they can go in there and do the renewal that way. One kind of tip, if you are doing it paper or if you've done it on the phone and you want to submit documents afterwards, if you know that something has changed and it's likely that the state is going to need verification that that thing has changed, go ahead and send those documents up front. It's gonna kind of reduce the processing time for everyone to make sure that they have everything they need to do that eligibility determination kind of the first time they look at that renewal. So then the notice comes, right? So if that's successful again, great, person gets a notice of action. It says you're approved, here your new renewal date, fantastic. If it is not returned, or it is returned and the information shows that the individual is no longer eligible or is only eligible in a limited benefit category, they will get a notice. They're required to be sent a notice. It has to be sent 11 days prior to the termination or reduction in coverage. I know with slow mail, a lot of times people get them like on the day or a day after. They are supposed to be getting them before, but I think there's just a lot of factors that make that difficult. It has to include a reason for the termination. So they have to tell you why you're losing the coverage or why the coverage is being reduced. And it will include information about how to appeal that decision. So if someone gets this notice and they're like, that's wrong, they do have the opportunity to appeal it, and they should be told how to do that. Our coverage, we're kind of a monthly coverage program. And so the coverage always ends on the last day of the month. And then if it was terminated because the individual just didn't return that renewal package, they do have this 90-day window to submit that renewal package. If it's approved, the coverage goes back, but you would have had a gap in coverage. And so they would have been taken out of their MCO, all of that. The retroactive reinstatement back would be fee for service. And usually the system does and should assign them to the same MCO that they were in previously. But it could assign them to a different MCO, right? So even though we're getting into coverage and technically we're having retroactive coverage cover our gap, so if there were services, you could have providers request that they resubmit those bills. There's still churn there. You're in, you're out, you're in fee for service, you're in one MCO, you might be in another, and then if you want to switch back, that takes a little bit of time. So really the goal is to prevent people from hitting this point, right? We want them to get enrolled through ex parte or through that renewal package, or if they're not, eligible, help them figure out the plan to go and make sure the next coverage option is lined up so that there's not so much or any gap in coverage. And again, if it's outside that 90-day redetermination period, the individual will need to submit a new application. Medicaid coverage, luckily, can go 3 months retroactive, even on a new application, but the individual generally should indicate on the application a question that says, do you have medical bills from the last 3 months? They would want to say yes on that. And also our CHIP program, so the famous, a little bit higher income program for children and pregnant persons, are not retroactive, so just the Medicaid is. And then just a few really high level notes about appeals. You have to do it within 30 days of the termination. or if you have good cause for filing late. So if you have your mail and the envelope that the termination letter came in and like it's clear that it was delayed based on the postmark or something like that, you could get a little bit more time. Individuals can request that they keep their benefits during the appeal, but they have to request that within 10 days of the termination or before it happens. And if they lose the appeal, they could be responsible for paying for the cost of that coverage. And then really important, so the state must accept new evidence of eligibility during the appeal. So if they're saying you were terminated because you submitted pay stubs, but the pay stubs weren't enough, and so we couldn't verify really what your income is. During the appeal process, you can submit additional pay stubs or additional information to verify what your income is and get back into coverage. So that's kind of the process. So I'm next going to step into what generally the outcomes of the renewal process is going to be. I'm going to pause one more time here just to see if there are any additional questions about any of that.
Yes, sir. There was one question that came in just about what do you want to talk about? It's the facilitated enrollment that via the checkbox on the tax return. Will that'll impact the renewal process at all?
No, it shouldn't. That's really right now the state has it set up where you check that box and then the state will send you information about Medicaid and how to apply, but it doesn't serve as an application for Medicaid. And so it's really an indication for the state to provide outreach to that individual, but it doesn't get that individual kind of into the system at all, so to speak, or into the eligibility or application or eligibility determination system. So it shouldn't impact it at all. So I helped work on that legislation, and I know, hopefully one day we could move to where we could kind of use tax data to make it either a very easy enrollment process or an automatic enrollment for some folks. But I think in Virginia we're pretty far away from that. But Maryland has done some really cool things if you're interested in learning more about the way facilitated enrollment could work in a more robust capacity than we have it in Virginia right now. Okay, so our kind of common renewal outcomes are the renewed coverage ones, right? Like these are easy. I'm not gonna spend too much time on the left side, but someone is just renewed into the same coverage category, or someone is renewed into a different full benefit category. Again, I mentioned earlier, if a child is no longer, 18 or under, if you're not within your postpartum period or pregnant, you can't be enrolled in those categories anymore. You've had a change in income that puts you in a different place. There are some individuals, and I'll spend a little more time on them, where now they're only eligible for a category that has different criteria than what they were eligible for before. I think the biggest example of this is individuals who are in Medicaid expansion and have now turned 65 or become Medicare eligible from having a disability. They cannot be in Medicaid expansion, so now they have to be assessed through the ABD categories or Medicare savings programs. But all of those categories have a resources and asset test. So these individuals are going to be assessed for Medicaid using kind of stricter criteria. And so that's just something to kind of think through when we're working with these people who are going to be looked at in a different category of Medicaid. And then the benefits may vary slightly from group to group. Not huge benefit shifts, but there are some slight variations between different categories. So just to note that as well. And then we're going to have folks who have either had their coverage reduced, and by reduced I mean they were in a full benefit Medicaid category and they've been moved into a limited benefit category, or terminated. And so, I kind of bucketed people into four main groups here. There will be individuals who are terminated but are still eligible. Often these are those administrative terminations, the return of mail, they didn't respond to a renewal package, something like that. There's going to be people who are moved into the limited benefit program. Their income's gone up and maybe they were in Medicaid expansion, but now they're over income for that, but they can still get planned first, which is the family planning services category for Medicaid. People who are ineligible but can and should reestablish eligibility, and I'll talk more about that later because I think this is a pretty complicated group of individuals. And then folks who are just ineligible, and they have to go to new coverage, right? They have to go to a marketplace plan, they have to go to an employer. Some folks will be newly eligible for Medicare and have to figure out if they're going to be enrolled just Medicare or Medicare and some kind of Medicaid to supplement it. And so helping people kind of, if you're no longer eligible, figure out where they can get coverage. So this first group, what should someone do if they're terminated and they feel like they are still eligible, they believe they're still eligible, or we're working with someone and we're like, oh, well, based on everything you've told me, you're still eligible, you probably shouldn't have been terminated. What do we need to do? The first thing I think I would do is say, like, okay, how long ago did you get that termination notice, right? Because this timing is so very important again. If it was within that last 90 days and the denial is because they just didn't return that package, I'll be like, great, let's submit your renewal package, let's get you back into coverage. If they were terminated because the state data, maybe it looked like they were over income, but they're not, they have variable income, we could submit an appeal if we were in 30 days of that eligibility notice. Or if it's after 90 days or the termination was not for a failure to respond to the renewal package, we would just submit a new application. And again, that for Medicaid can go retroactive up to 3 months if they were eligible during those 3 months, right? So they're not going to give you retroactive coverage if you were over income for those months. And it can actually be faster than filing an appeal. So for some folks, if it's not, there's not like an urgent need for the appeal to kind of preserve coverage within that during the appeal period to get a specific date back of a type of service. A new application can be a faster way to get them back into coverage because applications need to be processed for within 7 days for pregnant individuals and 45 days for most others. And an appeal can take up to 90 days. So just kind of thinking about that timing. And again, the timing is so important because there's still going to be like some churn in the type of coverage at the very least between fee-for-service and MCO if someone is terminated. So just keeping kind of that in mind and helping people kind of walk through that process, especially individuals who really need to be accessing services or getting medication during that time. For individuals who are moved into a limited benefit category, the process is a little bit different. So if they believe that they're still eligible for full benefit coverage, they say, the state said my income was 150% of the federal poverty line, so they moved me into plan first, but actually I'm at 120%. Here's my information that verifies that. I should still be in Medicaid extension. I still should be in this full benefit coverage category. Well, they still have a case. And so there's not the kind of need to do a new application or submit they can submit the renewal package to the caseworker if it hadn't been submitted with the verification of the continued eligibility, right? They still need to kind of communicate with that local caseworker to make sure they're getting the information to process basically the partial review with the lower income or whatever it is that is going to hopefully put them back into that full benefit category. You can also appeal a reduction in services. So an individual could appeal. If they did submit a new application, it would be denied for a duplicate application because they already have a case. And so, the process for fixing that is a little bit different. And then if someone believes that if the reduction was appropriate, if my income really has gone up and I'm not eligible for Medicaid expansion anymore, we would want to look at what their other coverage options are or how to reestablish eligibility. And again, I'll talk about both those in a little bit. And just kind of one note, if the new coverage option is the marketplace, so the ACA plans where you can get subsidies, a reduction in services, so being put into a limited benefit category in the eyes of the marketplace counts as a termination. And so that individual can get a special enrollment period to enroll outside of open enrollment. But it's a little confusing because folks will be like, well, I have Medicaid, I have plan first. But because that doesn't cover everything, it doesn't cover emergency service, it doesn't cover a lot of things. It's not considered full. It's not going to keep you out of the marketplace. Okay, so for those who were found ineligible because they are ineligible, but Medicaid is really their only option, and they need to reestablish eligibility. What I mean by this is predominantly individuals who are in Medicaid categories that have asset and resource limits, and they have now accrued excess assets or resources during the public health emergency. So since March of 2020, a lot of things can happen and change. But if their income is still really, really low, and they couldn't afford coverage elsewhere, we need to talk through, okay, how can you properly reestablish your eligibility? And the pathways for that will depend on the category of Medicaid and the specifics of the case. So all of this is really high level. I will also note, like, the categories with assets and resources are older and more vulnerable individuals, right? It's predominantly the aged, blind, disabled, so individuals on supplemental security income, individuals who are receiving long-term services and supports either in the community or in nursing homes, individuals over 65, and individuals with a disability. One note about individuals who are under 65 and are not Medicare eligible yet can still be eligible through Medicaid expansion. So there might be some folks who are in ABD Medicaid due to a disability, and if their assets have gone up, they can be redetermined into Medicaid expansion. But if someone is over 65 or already eligible for Medicare, that the only categories they can really enroll in Medicaid through are these categories that have asset resource limits. So some examples of what folks may have experienced is if someone that would have kind of increased their assets is if someone received an inheritance, if someone was in community-based care and moved to a nursing home. Basically, when you're in community-based care, you can keep more of your own money because you're still in a home, you're still buying your own food. When you move into a nursing home, that is greatly reduced. But for individuals who made this shift during the public health emergency, that patient pay wasn't reduced, so they were still able to keep more of their own money. So if that was just going into a bank account and not being spent, they may have accrued more than the pretty low resource limit that we have in Virginia, which is $2,000 for an individual, $3,000 for a couple. And so that's something that family is going to have to try to figure out and work through, because if someone is in a nursing home, we don't want them losing coverage. We want to be able to kind of preserve them and keep them getting the care that is so very obviously necessary for them at that point in time. If someone has held on to all the pandemic relief payments that they've gotten and haven't spent them, and they're kind of sitting there in a bank account somewhere. And then individuals who are in a spend down. So a spend down is for individuals who have really high medical needs. They have a lot of medical bills, but they're over the traditional income limits. They have to have, basically it resets every 6 months. If they have enough bills, they've spent enough money on medical care, they'll get Medicaid for the remainder of that 6-month period, and it resets. Well, it wasn't resetting because we weren't allowed to terminate or reduce coverage for anyone. And so potentially they've been able to keep more of their own money because Medicaid has been paying all those bills. It wasn't resetting and requiring them to spend X amount of money every 6 months to get Medicaid coverage. And so that's going to be something to look at for those individuals. I think that's also going to be a pretty complicated situation. I don't really have good answers like on the other slides where I'm like, here are the steps you take, again, because it's going to be pretty case specific. There are some things I'm watching right now that may address some of the challenges with this category. So first, there was in the last General Assembly session, the final budget had language in it waiving assets and resources, excess assets and resources for individuals who are receiving long-term services and supports, right? So folks who are getting long-term care for 12 months at the end of the PHE, at the public health emergency. DMAS is going back and forth with CMS to kind of put regulations out, guidance out around this, so we know exactly what's going to be waived and what the process is going to be. But I'm definitely keeping an eye on that so that we can help provide guidance to folks when it does come out. And then the Social Security Administration has already come out with guidance that defined all pandemic relief payments in a way that says they're permanently waived from being considered an asset for an SSI recipient, a supplemental security. And Medicaid rules are very closely tied to SSI rules for the assets and resources. And so we're waiting on the federal Medicaid agency, the Center for Medicare and Medicaid Services, CMS, hopefully to put out mirror guidance that says, we will also waive this, and then kind of the process for how you know which money came from the pandemic relief payments and which didn't, to be able to verify that that is in fact a waivable asset. And then I just think there's also, I kind of mentioned this category of folks before, but another kind of group of individuals where it's going to be a trickier transition is individuals who have become eligible for Medicare. Again, if they've turned 65 and they were in Medicaid expansion, or they were receiving Social Security disability and they hit their 24-month mark, they also would become Medicare eligible. And then they can't be in expansion anymore, because the expansion explicitly says if you are Medicare eligible, you cannot be in this coverage category. You have to be assessed using through a age blind disabled or a Medicare savings program, one of these other categories. I think I think it's important to acknowledge that there is a pretty big gap in eligibility criteria between Medicaid expansion and our ABD Medicaid, our full benefit kind of Medicaid for individuals who are older or disabled. Medicaid expansion has no resource limit, and your income can go up to 138% of the federal poverty line. All of a sudden you turn 65 and the income limit comes way down to 80% of the federal poverty line. And you have an asset resource limit of $2,000 for an individual, $3,000 for a couple. And so anyone who's kind of was in expansion but has resources or has income from 181 to 138 and above is going to have to figure out why they're no longer getting full benefit Medicaid. Then there's our Medicare savings programs, which there's several levels of them, and they help pay your Medicare premiums and the lower level sum of like the supplemental services. And generally folks also would be enrolled in the low income subsidy to help pay for the Part D if they're in a Medicare savings program. But it's a lot of pieces to have to put together. Another kind of complicated factor is that if someone was in Medicaid expansion, they very well may have missed their Medicare enrollment period. And when you don't enroll in Medicare when you're first eligible, there's penalties for Part B and Part D, and those penalties compound over time. You pay them forever, and the longer you've not been enrolled when you've been eligible, the higher those penalties get. There is a proposed rule that CMS has put out that will give a special enrollment period, a Medicare special enrollment period, when an individual loses Medicaid. So if you've been in Medicaid and that's why you didn't enroll in Medicare when you were first eligible, they're going to give you a special enrollment period and waive those penalty fees. But it's still proposed, so we're waiting for the final rule hopefully to come out. I know the comment period ended back in June, so hopefully that'll come out. And then just it can be really complicated. Again, if you are still eligible for Medicaid or through ABD or a Medicare savings program, you still have to apply for Medicare separately at SSA, and then the coordination of Medicaid paying those Medicare premiums. Again, just can be a pretty complicated dance. And so this is there's just going to be a lot to figure out, and we should definitely keep our eyes out for folks who just get lost in the administrative barriers of it. And then I leave my easiest groups for last because these are the groups I'm kind of most familiar with myself, is that if you're no longer eligible, you can go to the marketplace. If you don't have an offer of affordable employer coverage, you get a 60-day special enrollment period that starts from the termination. If you apply within 60 days before the loss of coverage, you can even prevent a gap in coverage. It is not automatic. People do have to go into the marketplace and do the application and enrollment. Again, just to note, the limited benefit Medicaid will not keep you out of the marketplace or keep you out of eligibility for tax credits. And then because we would like to make things extra complicated, Virginia is currently using healthcare.gov as our marketplace. In 2023 for plan year 2024, so November of 2023, when it's open enrollment for the plans for 2024, we're actually going to be moving to a state-based exchange. And so folks are going to have to be going to a new portal for that. And so we're just going to have to communicate that really clearly so people know where to go to get this coverage, because that is likely going to overlap with that 12-month unwinding period. If someone has an offer of employer coverage that they're not enrolled in, again, employers do give a special enrollment period. Usually employers' SEPs are 30 days, but there's some special rules around the loss of Medicaid or CHIP where a lot of folks should be given a 60-day SEP. I think it's a pretty niche, kind of not super well-known rule. So some employers just may not be aware that that's what they should be offering. And then more people who are offered really expensive employer coverage should be able to get marketplace coverage as of 2023 due to a change in what we call the family glitch rule at the federal level. And I know I'm starting to get close to time, but I can talk more about that if anyone has questions after. Just here's some other things to consider. You know, DSS offices are already overwhelmed, and when they have to do all these redeterminations, their workload is going to go up about 40%. So it's just going to be, it's already can be challenging to get in touch with a worker. There's high turnover. So if your case has been turned over to a new worker, and we're just going to have to work through that process together. I don't have any good tips there. Again, that kind of overlaps with staffing challenges that are being experienced kind of across the board. The notices can be complicated. Again, there's not a lot of integration between ACA, Medicaid, or Medicaid and Medicare, so it can be chunky transitions. Again, the transition to the state-based exchange, there's just a lot we don't know. So how do we communicate about this when we don't know when the public health emergency is going to end? We don't know if CMS is going to put out more guidance. And so it does present a lot of communication challenges because there's a lot of questions we just don't have the answers to yet. And then obviously Medicaid serves a vulnerable population across the board. And so we are working, with folks where we just always need to be more conscientious and thoughtful about how to engage, about how to communicate, and really what the consequences are for these gaps and losses in coverage. And I have 2 slides left, I promise. So these are just, the state has done a lot within their regulations and their guidelines and their program to try to ease the burden of unwinding when it does happen. There are still some federal options that the state could adopt that would need kind of legislative approval to do so, or legislative directives to do so. One is 12-month continuous eligibility for children, right? So a child who is enrolled in Medicaid is just eligible for 12 months, even if something changes. We know a lot of kids who fall out of coverage because their income goes up, the family's income comes right back down. So they're eligible again within 3 months. And so it's in and out of coverage. So just providing that continuity of care can be really important. We have a Medicaid program for children and a CHIP program for children, and it just is administratively more burdensome to administer. And then kids will be shifted between the two. Merging them would just kind of streamline that enrollment process for kids and prevent kids from having to be moved back and forth. So if we know they're eligible, we're not going to have to get verification of income to move them from the Medicaid to the FAMUS program or vice versa. We just know they're covered. We do not automatically enroll our SSI recipients into Medicaid. We are one of 8 states that does not do this. And we don't accept SSI renewals as Medicaid renewals. Again, those rules are very closely tied. SSI recipients are eligible for Medicaid because if you meet the criteria for SSI, you meet Medicaid eligibility criteria in Virginia. And there is a way to just automatically accept that. Implement an asset verification system and accept member attestation of 0 assets. So basically we want to move to where we will start to be able to do ex parte for our categories of Medicaid enrollees who have resources, who have assets. We've gotten really good at it for our folks who don't have those requirements. And hopefully we can move towards a system where we can do more automatic renewals for the populations who aren't eligible for it right now. And then just looking at new and different ways where we can enhance our electronic communications. Common Help is the online portal where you can do an application, but you don't get your notices back that way. You can't really submit documents after you've submitted the application, right, through your online portal. And so some of those enhancements I think would be helpful for members as well. And here's a list of things that just kind of, because we don't know the dates and when it's going to end, again, the communication is hard, but there are a few things that I think we can do now. Just really first and foremost, making sure members' addresses are up to date. If the state cannot communicate with them, if they don't get their renewal, they're all but guaranteed to lose coverage when the renewal comes up. We just want to make sure that they have, the state has the information so that they can communicate with them. You can do this by calling Cover Virginia. You can go to covervirginia.org and enter their updated address. They can update their updated address, or they can contact their caseworker at the local DSS to do that. If we are working with vulnerable populations who we know are going to have to transition into a different coverage category, or who we know have extra assets that they'll have to reduce in order to maintain eligibility down the road, start making a plan for that now. Reaching out to our partners, building these bridges, building these referral networks, I think will be really important. Planning our member outreach and education. And then you can get direct information from DMAS, the Department of Medical Assistance Services, which is the state department that administers the Medicaid program. You can get their newsletters. They have bi-monthly stakeholder meetings or online meetings. You can attend to get up-to-date information from them. And yeah, this is my last one, I promise. I said 2, I lied, it was 3 more slides. I really wanted to note relatively quickly that while the kind of the biggest thing we're going to be dealing with when the public health emergency ends is the ending of this continuous eligibility requirement and all of these renewals. But there were also several emergency Medicaid waivers and flexibilities that we implemented during the public health emergency. And the authority to do those things was directly tied to the federal public health emergency. And so when that ends, some of these other flexibilities are also going to go away. So like I can use a verbal consent form during the public health emergency as an assister to provide remote assistance. That will likely go away. We've suspended appeal timelines, so we can submit an eligibility appeal right now 4 months after we got the notice. But when that public health emergency ends, it's going to go back to that pretty tight timeline of 30 days. We suspended copays, we had telehealth flexibilities, and all these other ones that we listed. To note, the ones with stars are ones that the legislature did take action to kind of permanently implement in whole or part of them. And so there has been some recognition that these flexibilities are good and we want to keep them around. And so there's been some action towards implementing permanently the ones we liked and the ones that are allowed to be implemented permanently. Not all of them have a permanent option. And then here's just some more resources from CMS and DMAS on the unwinding, their guidance, their plans that you can go. And I'm going to stop sharing, so I'll be able to kind of read the questions as well. But Amber or Deepak, if there's anything that came up, feel free to just shout it out and I can try to answer.
Yeah, thank you, Sarah. That's great. Yeah, and so if anyone has questions, you can use all of them. You can use the chat feature. There's a cute question and answer module, and then I think you're also able to raise your hand as well. We've about 5 minutes or so here left.
RSLA asked a question about undocumented pregnant women in public charge. So public charge is a federal rule that's like that is related to the immigration system. If someone has received certain public benefits, they may be considered more of a public charge, and that may impact their ability to adjust their immigration status. Pregnancy-related coverage is not included in the public charge assessment. It's cash assistance and long-term care and I'm forgetting one, but pregnancy-related assistance is not. Generally speaking as well, it's when someone enters the United States or is adjusting to become a legal permanent resident from a status. You kind of have to have a status or have a pathway to status for it even to matter. So it may be cases that specific for an individual who doesn't have current status as well. But no, it should not be held against them in a public charge. Generally speaking, Deepak knows a lot about public charge and answered in the question in the chat feature. So sorry, Deepak, I didn't even see your answer before I read that one. And there's some resources in there. And Mara put in the link to the DMAS newsletter, so please go ahead and check that out. And I don't see any other questions in there, so please shout them out or put them in.
Thanks, Sarah. Yeah, and just I put it in the chat, but we are recording today's webinar, and we will be sharing that to everyone who registered for the webinar. Sarah, if you saw, there's an additional question that came in just now from Clancy. Do you happen to know any resources for the immigrant community who would like to have insurance or low-cost healthcare access? And then question particularly for undocumented Virginians. Yeah,
so I would say, generally speaking, we have a really, Enroll Virginia has a lot of assisters across the state. We have a pretty robust team of individuals who speak Spanish, and again, have other supports for other languages as well. I know there's an immensely diverse immigrant community in our state. Specifically, there's a pretty big distinction for options for coverage when someone has status versus when someone does not have some kind of status. So if someone is legally residing, which means they basically have any kind of status other than deferred action for childhood arrivals, as we in the healthcare world have decided to define that as not status for these programs for some reason, they can either get Medicaid or ACA coverage. If someone is legally residing, they're not eligible for Medicaid because they don't make those strict criteria, they can get ACA coverage and tax credits, even if they have income that's like below the threshold for everyone else. So if this person would normally be in Medicaid, if they're a citizen and they're eligible for Medicaid, they need to take Medicaid. If they have a work visa and a pending asylum case, they are not eligible for Medicaid, but they can get ACA coverage. And so I would, first of all, encourage, I think that is a very underknown and underutilized fact for the immigrant community. And so please send folks our way who have, status. Generally speaking, we can find something, at least for their option. When someone does not have status, when someone is an undocumented individual, it gets a lot more difficult. So Medicaid newly does cover pregnant individuals who are undocumented, but that is the only Medicaid coverage. They also cannot purchase ACA coverage, even at full cost. And so sometimes individuals can find coverage directly through like a broker, but unfortunately, there just aren't a lot of good comprehensive insurance programs that do cover undocumented individuals. Some employer plans, some folks are covered through employer plans. But outside of that, utilizing the free clinics, the federally qualified health centers. I know in Northern Virginia, Deepak, correct me if I'm wrong, is it Kaiser that has the program that covers individuals, or is it Inova who aren't eligible for other programs based on their immigration status? So I wish I had a better answer for that population. Unfortunately, I don't.
Yeah, and there was just a follow-up from Deb Bratton about filing taxes. I think that was for filing taxes for immigrants who are illegally residing but eligible for marketplace coverage and tax credits. And that's, yes, they would, to qualify for premium tax credits, they would need to file taxes for the tax credits, but they are eligible for it.
So they'd have to be legally residing, right? So if someone is not legally residing, if they're undocumented, they can't get tax credits regardless of if they file taxes or not.
Just had another question come in asking, what is the process for Virginia moving toward easy enrollment as done in Maryland?
The process right now is that, again, we have that checklist on the check form on it, and if you think that's a great idea, I'd love to talk to you on the side about how to work with legislators to kind of get some motion and action towards making it a more robust process.
Yeah, I don't see any additional questions. Thank you, Sarah.
Well, thank you all. As Deepak said, we will record this. It was recorded, so we'll send it out. And we can send the slides out as well, which has my email in it. But if you just go to Virginia Poverty Law Center, my information's on there as well. So please feel free to reach out with any questions that come up down the road. And just thank you so much for joining today. I hope it was helpful.